breast are they seeing it come from? Is it one specifically where there might be an isolated infection there? Do they feel any pressure on the breast? Did it happen? Does it just spontaneously occur? Are they just wetting bras at night? Or are they basically pushing stuff around? You shouldn't have to be that aggressive, okay? Is it related to menses? Are they pre- or postmenopausal? And what medications might they be on? So the concern that you have is if they are having a simulation of a suckling reflex, it can be secondary to breast implants. Really aggressive foreplay, again, if somebody's really massaging the breast tissue, believe it or not, you can start to get drainage from the breast. So the treatment plan is just cut it out, okay? And that will usually fix the problem. Any type of trauma, are they doing really aggressive? Is this the woman who's really hyper concerned that she has breast cancer because maybe now her sister just got diagnosed or her mom just got diagnosed, and she's being a little bit too aggressive with breast examinations? Believe it or not, women can self-induce some drainage from the breast because they're trying to squeeze, they're trying to find something. Again, it's like all things. If you look hard enough, you'll find something wrong, okay? So just, they shouldn't be that aggressive. You shouldn't need to be that aggressive for self-breast exams. So medical causes, we look at all types of medications. Again, the vast majority of these are going to raise your prolactin level. But even when you're talking about verapamil, okay? But the vast majority of these are like your anti-psych medications, antidepressant medications. CNS lesions, we're primarily going to look for pituitary adenoma. We want to make sure that they don't have a gigantic tumor that's sitting there. Again, you would start asking, well, do you have any kids? Have you had a hard time have you tried to get pregnant? Are you having a hard time getting pregnant? Kind of ask the follow-up questions. Some other random medical conditions, hypothyroidism, if they have liver disease, renal disease, hopefully or chronic, hopefully this category of female patient would not already have chronic renal failure, but she might, okay? And if they have chest wall lesions, similar in terms of herpes zoster, if it's basically going right across the nipple line, and that's where she's having her outbreak, is that what she's concerned about as being breast drainage? And yet it's actually just, shingles, okay? Again, remembering that T4 is a nipple line, okay? Concerning disease, so if we have unilateral drainage, because typically unilateral is going to be a little bit more bloody. Again, if it's pink colored, non-milky, discharge associated with a mass. If we have elderly patients, should not have elderly patients having discharge from the breasts. We want to always check a prolactin level, TSH level. We want to make sure that it's not an endocrine issue before we kind of jump to the big cancer word, okay? So we talk about a breast mass, basically going to ask the patient about how long it's been there. Vast majority of women, unfortunately, do not do self-breast exams, although they should. They're like, oh, I wash in the shower. I would hope you wash in the shower. But they don't actually take the time to do a breast exam to know what might be different, okay? So determine the family risk factors for breast cancer. That definitely goes directly to their Gale score. Do a physical exam, clinical breast exam. You want to know if it's a mobile lesion or if it's fixed to the chest wall. Again, have them raise their arms up, put their arms on their hips and push in. Have them lean forward. When we talk about mammograms, so we talk about digital mammography. So most women will get their digital mammogram once a year. It's really not as bad as everybody says it is, okay? But you go and you get your mammogram done, and 3 days later you get your results, or 5 days later you get your results. A screening mammogram, they typically still want these to be done about the age 40. Every time they talk about this, everybody gets all in a brouhaha when they try to change the age, right? A diagnostic mammogram, again, you're typically looking for a specific breast problem, although I will end up having a spot down view and she ends up getting an ultrasound, and then they end up telling her it's fine. Just go ahead and order her a diagnostic mammogram, okay? Because granted, you have to sit there for 3 hours, but the nice thing is you get your results that day, and whatever additional studies you need are inherently built into the diagnostic mammogram, okay? I have one friend, she drives me crazy. Every year she ends up getting a diagnostic mammogram after she gets a regular mammogram. So they write her for a regular one. She's like, 3 days later, I'm worried. They found something. Of course they find something. They always find something on her, okay? I've got to go back and have more views. I'm like, why do you do this every single year? Have them order you a diagnostic mammogram. Granted, sometimes for some of your patients, based on insurance, it may not be covered straight out, but it's like $200. You sit there for 3 hours, you know your results. Totally worth it, okay? Mammogram alone cannot prove if an area is cancer. And so that's why they'll typically supplement that with ultrasound, especially when they're talking about cystic lesions, because it allows them to delineate those structures better. So again, we talk about ultrasound. MRI for your very high-risk patients. If you talk to my old boss in town, he'll tell you that MRI has increased the number of mastectomies. It has not changed the survivability for breast cancer. So we'll talk about today about lobular carcinoma in situ, which is not identified on mammography. It's found on MRI. So you end up start biopsying this little thing and that little thing and this little thing and that little thing when we do MRIs. Okay. Fine needle aspiration. So if we're talking about removal of fluid, if we do have that cystic structure and we're concerned that it might be cancerous, you can actually do a fine needle aspiration of that area. Certainly you can do fine needle biopsy of that area. Understanding that every single time you do a fine needle biopsy, especially a breast biopsy, they leave a marker, a little teeny tag in there. So you do cause some change to the construct of the breast tissue, and you are causing some scar tissue. So next year when you go in, well, was that the marker, or is that scar tissue, or is that new? That's the problem with biopsy after biopsy after biopsy. Okay. All right, so benign breast conditions, how are we? What are we doing? What time is it? Okay, a couple more minutes and we'll go. Yes, ma'am.
Can you go back to MRI? What was the high risk reference?
For your patients who are at high risk, so in terms of surgical planning, they might go for an MRI just to make sure that they're not missing something else. Certainly it helps in terms of evaluating if the mammogram was normal on the contralateral breast, you could do an MRI. Certainly, Josh, to your point about the talus fence versus lymph node, MRI is going to tell you if this is within the talus fence or is it lymph node involved.
But otherwise, they were overusing MRIs and.
That's my old boss's opinion.
Oh, okay.
Yeah. But most across the board, ACOG will recommend an MRI. But again, MRI increases the number of mastectomies. It doesn't change survivability from breast cancer. So we're operating on more women, not necessarily changing how long they live. Okay? Because how long they live goes directly to their path findings. Okay. All right. So when we talk about fibrocystic disease, very, very common. It's a condition. It's not a disease. It will get better. It is directly cyclical related with regards to menses. It is directly diet Mountain Dew related. Okay. The more caffeine women drink, typically the worse they are with regards to fibrocystic changes. So they're typically rapidly fluctuating in size, again changing with hormonal levels throughout the menstrual cycle. This would be the woman that if you evaluated her and she's mid-cycle, don't bring her back in 4 weeks. Bring her back in 5 weeks or 7 weeks. Evaluate her at a different time within the menstrual cycle to see if things have changed for her. Presents about 33 to 50% of all women, symptomatic in half of them. So the vast majority of women will have changes to their breast tissue. They'll know that something hurts, but they'll know that, oh, this is always there. This lump, that's always there. This is the one that's different. Okay, so most women who have fibrocystic changes to the breast and are more symptomatic about it, I will say they're a little bit better about doing self-breast exams because they kind of know what's normal for them. So that they may have pain, they have fluctuation in size, they typically have multiple lesions. Basically, larger masses have to be evaluated with biopsy because you do have to make sure that it's not breast cancer. And again, typically we're talking about a little bit younger population for this disease long term. You can aspirate the area or do ultrasound on it. Usually the ultrasound will delineate out, even if it's a cystic lesion, kind of is it dirty cyst, or is there a lot of fluid in the area? And then you can continue to follow that same cyst with repeat ultrasound to see if it's going away, rather than necessarily having to just stick a needle in it. Okay. Again, remember that these patients are younger. Mammography might be helpful, but it's also difficult. The best mammogram happens on the woman who's had a couple kids. She's breastfed every one of them for like 6 months, and she's like 44. Okay. And she's maybe a B cup, okay? Because seriously, you get larger breast tissue, it's harder. You get denser breast tissue, it's harder. So your woman who's never had children, never breastfed, has very pendulous breasts, they're just more difficult to assess, okay? Conversely, your woman who has really, really small breasts, those are also hard because they're just hard to get a really good digital mammogram on. It's hard to get that much. All you guys know how those happen, right? Literally, like, and my friend had one. So my friend is a guy, okay? He had a breast mass, because we'll talk about men, they can get breast cancer too. He's like, I had this mass, I'm like, you're gonna need a mammogram. So he goes to get a mammogram. He was like, I can't believe you girls have to do that every year. I'm like, you think that's bad? Go get a pelvic exam. He wasn't up for that one either. But basically, they scrape the machine down your chest wall, and you can basically feel it bump over your ribs to flatten out your breast tissue. It's very comfortable. No woman is saying, that's fun, let's do that again next week. They just doesn't happen, okay? I mean, they're not that horrible, but you certainly are happy that it's only a yearly screening. So breast cyst aspiration, if it's simple, you can typically take a 22 to 25 gauge needle. If you're nice, you take a 25 gauge needle, but the problem is if you're really that nice, you're not going to get the fluid out that fast. So you go with the 22, okay? And you basically want to make sure that if it's straw colored, it should be this fibrocystic issue. Sometimes you'll get darker brown or green changes, but again, you're going to send them off for culture, make sure there's no underlying infection in the area. But basically, that's how you do it. Kind of locally knot up the area, you go right in, drain the cyst. Quite oftentimes, we use ultrasound-assisted guidance because it allows us to actually actively see that we're going into the cyst itself to drain the lesion. Then you send it off for cytology. Okay. So you can treat them with oral contraceptive pills. That's like everybody this week gets oral contraceptive pills. You can treat them with Depo-Provera for the woman who cannot take estrogen if either she doesn't want it or she has some type of contraindication to estrogen therapy. Non-steroidal anti-inflammatories. You can just tell them to get a really good bra. Okay. It is. I operated on this girl, 16 years old. She had the really big breasts, and we didn't even do anything breast related. She had a seizure disorder, so we were putting in a stimulator on her neck to help calm down her seizures. And you wrap it around the vagus nerve. It's actually a really good operation. But they put a generator in the chest just like you would with a pacemaker. Well, the problem is, so we go to change that. Somebody else put that in. We had to go change the battery 5 years later. Her scar was horrible because she had such pendulous breasts, and basically when they sewed her up, she never wore a good bra. So the whole scar line stretched as it healed. And I was like, well, okay, we'll revise that. I put her in a cardiac bra, like what they would use on women after open heart surgery. And she's like, this is the best bra ever. And I'm like, really? And she's like, yeah. So most women just need like good support, you know? That actually helps with the breast pain. So hold those girls up there. Okay. Dietary changes, so low fat, caffeine free, stop smoking. That typically helps. Make sure that they do self-breast exams. Again, make sure that they kind of get to know what is normal for them throughout their cycle. Make sure that if they're doing a self-breast exam, typically we tell women to do it once a month. But especially for the first couple of months, that woman, have her do it a couple different times throughout the month so that she knows what her cyclical changes are doing to her breast tissue. Just helps her become aware. Fibrocystic changes are associated with proliferative or atypical changes. Long-term, they have a higher risk of breast cancer. I don't know. I think what happens is they end up getting biopsied often, and eventually you end up finding breast cancer on them. Okay? So a lot of these women with fibrocystic breast disease, don't be surprised if you're like, you ever had a breast biopsy? Oh yeah, I've had 7. Kid you not. Okay? And then they keep getting mammograms, and then they end up getting an MRI, and lo and behold, something lights up on the MRI. Okay. All right, fibroadenoma of the breast is the most common benign breast problem. Yeah. Very common in your younger female patients, slightly earlier in black women, but basically 20 years of age. Firm, painless, mobile mass, 1 to 5 centimeters. They can be kind of big. Remember, 5 centimeters is about the size of a lemon. Okay, so they can get pretty big. Typically slow growing, no change with menstrual cycle, so it's slowly going to get bigger over time. Think of this almost how you would think of like a lipoma anywhere else in the body, okay, this large tissue. And they can become big. Now this can actually cause asymmetrical appearance to the breasts. Because truly, if you added something the size of a lime on most women to one breast over the other, you would notice that even if you just looked at the pendulous nature of the breast, it would weigh more. So it would be different on one side in comparison to the other. So when we talk about these, we want to rule out cancer if we've got our patients who are over 30. Very atypical for this to occur in your postmenopausal, menopausal female. Typically we excise them. We excise them for the fact that they're painful and uncomfortable. We excise them primarily because we have to get tissue. So why go in and get a biopsy? Just go ahead and remove the whole thing. Okay, that's typically why they're taken So cystosarcoma, which is kind of a misnomer. Rarely is this malignant, despite the fact that it's got that sarcoma in the name. But basically, it's a type of fibroma. It's it tends to grow more rapidly. So this isn't the woman who has a fibroma that's slowly been getting bigger and bigger over the course of years. This is the woman who kind of noticed it over the course of a couple months. So truly for her, you end up taking it out because, of course, again, you need pathology and it's bothersome. She's more worried about the fact of how rapidly it's gotten there, and it's been an appreciable change, than the woman who has a fibroadenoma. Fat necrosis is pretty rare, but we worry about that primarily after people have had trauma to the breasts. Believe it or not, you can actually get necrotic changes. You worry about this with guys too. So, for the man who's had trauma to the chest, say with a motor vehicle accident, you don't want him years later just thinking, oh, well, I had that seatbelt injury. Years later, that seatbelt injury to the breast tissue should not still be causing problems. Okay. So basically, you get ecchymotic areas near a tumor can be the possibility. So typically, it's self-limiting. Usually, it will typically get better. It will typically get better over time. If it persists, it demands to have a biopsy. Because again, you want to rule out cancer. I was talking with Professor B the other day. She said she had a gentleman come in, and he was, by the time then, he was like 80. Come into her office, and lo and behold, he had breast cancer. And he had been told years before, because we were just talking about this, we were setting up all the models the other day. Years before, he had been told, because of a car accident, he just had necrotic tissue to the breast. It'll get better. And he blew it off for years. And here, lo and behold, it was breast cancer. So, unfortunately, men, it's not common, but men get breast cancer as well. All right, so breast abscess. We talked about this a little bit the other day with regards to mastitis. Typically, we see this a little bit more so in our nursing women, those who have just had a child. Partially because we get that engorgement of the tissue, but more often than not, just because you have a little bit of breakdown around the areola, and we seek the areas typically with staph. So the concern is, if it's mastitis, typically we just see an inflammatory process to the tissue. Understand that we have a better blood supply to the superior aspect of the breast. So usually you'll see more of that erythematous change on the inferior aspect because we don't have as good a blood supply nor venous drainage in that area. If we haven't, so again, you still want to do a breast exam on these women, because if they fail conservative treatment, if they fail antibiotic therapy, you want to make sure that they don't have a loculated abscess, because if they have an abscess in the area, it would certainly need to be drained. Believe it or not, women who have mastitis who are on antibiotics can still continue to breastfeed. It's actually recommended that they do. Whereas if they have an abscess, you actually have to tell them to just defer from breastfeeding on that side. Okay. I had one woman, she was very nice. First child, God love her, man. She was a nice religious woman. I mean, not that I'm not, but I mean, she was like devout, And like nobody had seen her besides her husband. And she ends up with an abscess. So first child, she's like 24. So here she goes to the OR. Her surgeon's a guy. Here she goes for days. Now she's on IV antibiotics. She's got an open wound to the breast that we're packing every day. And every day, I tried to go there most days, but every other day that I wasn't there, some random other guy in my practice was having to pack her wound and look at her breast tissue. And she was just like, you gotta be kidding me. I've spent all this time and the only person who's seen me naked is my husband. And now I've seen all these random men have seen me naked. She was not happy. She did good though. Malformations of the breast, so pretty rare, but there's certain various, you can have one breast really not develop at all. You can certainly have one breast develop much bigger. Certainly some women develop very big breasts early in life. So they'll end up having essentially a breast reduction long term. Honestly, breast reductions are actually covered by insurance when we talk about upper back pain and shoulder pain for those women. So pretty rare for it to occur, but it certainly can. You can get an accessory nipple or accessory breast tissue somewhere else on the body. Believe it or not, 1 to 2% of the Caucasian population will have that. So just assess your entire patient. Problem is when we talk about accessory nipples, especially, it may still have drainage. So come pregnancy time, they may actually get drainage from that area as well. Okay. All right, let's take a break. We'll come back and talk about breast cancer.
If anyone did sign up for a time, I'm going to go turn in this to you.